I will request and invite Professor Zulfiqar Bhutta for his talk, and Professor Zulfiqar Bhutta doesn't need any introduction. He's a fellow of Royal College of Physicians and Royal College of Pediatrics and Child Health, the American Academy of Pediatrics and Pakistan Academy of Sciences. He is an inaugural Robert Harding Chair and co-director at the Sick Kids Center for Global Child Health. He is a founding director of the Center of Excellence in Women and Child Health and the Institute of Global Health and Development at Aga Khan University. His work has made an integral contribution to global policy to improve maternal, child, and newborn health. Recently, he received 2021 IHME Rocks Prize for significant research contribution to women and child health and John Dirk Canada Gardner 2022 Global Health Award, the most prestigious global health award in the world. His talk is regarding the community-based strategies for the prevention and management of neonatal infection and its implication in Pakistan. So, welcome, Professor Zulfiqar Bhutta, and thank you for joining us.
Thank you very much, Dr. Mean John. Chairs, ladies and gentlemen, I hope you can hear me. Well, I'm speaking to you from across various time zones, and I'm conscious of the fact that I've been asked to cover a very vast landscape in a little over half an hour, so I'll try and get to it straight away. But let me start by saying that of the various global health inequalities, it is really the inequality in healthcare that's the most shocking and inhumane. That's been fairly well known for a long time. But what is really very jarring are the global differentials that we face in newborn survival. And in many countries, the subnational differentials that we have in newborn mortalities. Today, despite the fact that we have made considerable progress over the Millennium Development Goal period from 2000 to 2015, there's still close to around 2.5 million newborn deaths globally, largely clustered in sub-Saharan Africa and South Asia. And Pakistan has one of the highest rates of newborn mortality worldwide. Just to tell you how much disparity and aggregation of mortality is there in a relatively few countries, you can see this through this ranking of newborn deaths numbers. So of these 2.5 million newborn deaths, approximately 60% are in these 10 countries ranked here. And if you look at these 10 countries, they also contain about 60% of the global maternal deaths, just looking at the nexus between maternal and newborn. And very importantly, something that I really would like neonatologists to be talking more about in Pakistan are the aggregation of stillbirths, which are seen in the same geographies, close to around 44%. And about half of these stillbirths are in the intrapartum period. Now, we have some information on neonatal mortality, its causes by regions. These are the global data that we have available, looking at the major conditions that cause the 2.5 million newborn deaths, about 47% of under 5 mortality. The major categories are here. Neonatal infections account for close to around 600,000 newborn deaths by global estimates, largely divided between the various categories that you see here: sepsis, meningitis, pneumonia, and others. And yet it remains a relative black box for etiology overall. We do know, however, that as you transit between various countries by development or by levels of mortality, that neonatal sepsis assumes a much greater importance. And certainly in the countries with high rates, greater than 30 per thousand neonatal mortality, we see a pretty significant contribution of neonatal sepsis to neonatal mortality. For a long time, there has been an issue about the data from Pakistan. So I did want to share with you, as I did in early March, the findings from the recent Pakistan mortality survey that my group undertook on a national sampling frame, which was based on district sampling across various parts of the country. You can see how widely distributed and representative this was. This survey covered about 760,000 households and around 500,000 live births within the recall period. And the overall mortality rates that we obtained as part of this survey were broadly consonant with what had been seen in the Demographic and Health Survey on a much lower sample. The point I want to drive home here is that our stillbirth rates are around 30 per 1,000 total births, which is close to the 40 per 1,000 live births for neonatal deaths. We were also able to undertake verbal autopsies, and our team led by Dr. Zulfiqar and Shubin oversaw close to around 2,100 newborn verbal autopsies, in addition to others that I will talk about another time. And these verbal autopsies revealed the following picture in Pakistan. Overall, for newborns, about a third of all deaths are related to perinatal asphyxia, third related to neonatal sepsis, meningitis, and about 18 to 20% to preterm births and complications. But if you divide this by early newborn period, neonatal sepsis also raises its head by contributing to about a fifth of all deaths in the early neonatal period. And once you go beyond the early neonatal period to the late neonatal period, let's say covering the 7 to 28 day period, this assumes a huge proportion of about 3/4 of all newborn deaths. So it is an important issue, it requires concerted action, and it is a major killer. The other important thing to note is that despite progress and despite change in facility births in Pakistan, we still have a pretty high proportion of neonatal deaths occurring at home. It's not like 50, 60% 20 years ago. We have a figure close to around 38%, and about half, or slightly more than half of these deaths taking place in hospital. So as we develop the next phase of newborn practice and public health strategies, a combination of primary care, community-based strategies, and facility-based interventions will be needed. But today I'm going to largely focus on the community side, on a preventive and promotive side. The next big question is, what do you know about the etiology of neonatal infections in Pakistan or South Asia? And is there any learning from studies that have been specifically targeted looking at community-based strategies? So some 20 years ago, Dr. Anissa Zaidi led a large systematic review that we were also part of, looking at the spectrum of neonatal pathogens across the world by their location and their timing. And as you can see, despite the fact that the West and the data on early acquisition of neonatal infections largely restricted to group B streptococcus and like, we had a very high preponderance from information available from various settings of gram-negative bacteria. This was also noted in terms of rural referrals and maternity centers based in those settings, home deliveries where the limited amount of information was available. So it looked as if, despite what was known in the literature, we still had a lot of evidence of environmental pathogens. These are gut-derived pathogens causing neonatal sepsis very early in these settings. And that could relate to things that are either acquired through unclean practices or may even relate to vertical transmission in some instances. Our general evidence from the AKU experience over this period of time, I haven't shared these data before because I've been looking at it for several decades now. But if you look at pathogens isolated in the first 48 hours across the board in AKU births, close to around 85,000 births, you see a fairly high preponderance of these pathogens. So they do account for a very significant proportion of infections in newborn infants. We had very little knowledge from community settings or population settings until we set up this large Anissa study between Pakistan, India, and Bangladesh some years ago. A very large investment, close to around $45 million, was spent on looking at this. And in this particular study, we had 5 sites across Bangladesh, Pakistan, rural, urban, Vellore, and Orissa in India, largely rural settings, but some peri-urban, and fairly large population bases with a reasonable birth cohort. The protocol of the study was also a very intense protocol of observations of these newborn in the first few days of life, following a first assessment in 24 hours, and then follow-up visits, as you can see, at different periods of time, with a case definition of sepsis that at that time was very close to what WHO has used for PSPI. I mean, they had to be clinically unwell with all these notations that you see here, and several of the other issues that could be associated with hospital-acquired infections were excluded. What did we find? First of all, using the PSBI definition, a large proportion of these cases were clustered in the first 48 hours. So you can already see that over here. And the incidence was close to around 95 per 1,000 live births, fairly high. And if you just looked at the early onset sepsis incidence, close to 40 per 1,000 live births. If you looked at bacteremia, as you have possibly heard many times, the rates of positivity were very low. And although a large amount of effort was placed on reducing contamination rates, but blood culture isolation rates were generally low, and true bacteremia identified, and this was only in about 2%. So the incidence of culture-proven PSBI was very low in this population. We also discovered that this incident was related to clinical presentations, and for some things like fast breathing only, they basically were not septic. They probably had other pathogens, and I'll be talking a little bit about those in a minute. But the clinical correlations between manifestations and blood culture positivity was relatively straightforward, with more severe presentation being associated with positivity rates that you see over here, 2 to 4%, but fast breathing was not. What did we isolate? Overall, these are the Anissa data, and the pathogens were not detected just by classic BACTEC methods, but by PCR, which is much more sensitive. All of the known pathogens that I've talked about were here, but some were easier to grow in culture. As you can imagine, the streptococci were much more than Streptococcus pneumoniae or others. Notice that we began to see viruses, and we saw a whole host of viruses, and one of the most common virus that was associated with clinical manifestations was that of RSV, respiratory syncytial virus, with a 6-fold greater odds ratio of positivity in some of these symptomatic children. So a lot of investment of efforts, but it did turn out that it looked like we would have to look at clinical manifestations and presentation largely in terms of deciding how to best treat. And that leaves a big question that I will not have time to address today as to what is to be done for antimicrobial resistance. And as these pathogens emerge, as we know, the mortality rates associated with the resistant pathogens are generally significantly higher, the case fatality rates, than those which are associated with sensitive infections. But we have very little handle on that in community settings because we are not going to have that information at population level in most cases. Let me quickly turn towards what we know about the risk factors for neonatal sepsis at population level. And of course, poverty, poor living conditions, environmental contamination in which these births take place are very important risk factors for community-acquired infections, particularly for home births, so births in those primary care settings where there is not enough attention made to cleanliness. Or only a fraction of many of our primary care facilities where births are taking place in Pakistan have running water. And you can imagine with the current heat wave and water scarcity, this is not a trivial issue. But there is also the issue of the nexus between the mother and newborn. These are data from Gary Darmstadt's famous study in Bangladesh, where he looked at some of the timing of infections and timing of sepsis. And about 40% of the culture-proven episodes of bacteremia that he was able to identify were in the first 3 days of life, suggestive of acquisition from mother. And many of our own timing contribution also suggests a very important link between maternal risk factors and newborn infection. For example, if you have maternal infections as manifested by pyrexia in the 7 days prior to delivery, your risk of early neonatal mortality is significantly higher, and especially so if you're preterm, 7-fold higher in comparison with term babies. So there is a clear association with maternal conditions, and that is one of the reasons why interventions have to take that into account. I do want to talk about something which people don't talk about often, which is prematurity, often when it is associated with growth retardation. And these two babies may not be differentiated on the basis of weight only, but they're entirely different animals when it comes to clinical outcomes. And we've known now again and again that these small and vulnerable newborns, which is going to be the focus of attention in a new Lancet series coming out next year, are largely these babies here, particularly the small for gestational age, preterm low birth weight babies, those who are term and term normal birth. These are the small babies, in particular in this category, who have excess risk of infections and excess risk of mortality. And indeed, that is what we know. And across the world, where people have looked at cohorts, the relative risk of dying is the highest amongst those who are preterm and small for gestational age. Just to give you the numbers, we have looked at this in the context of AKU also. And if you are preterm and appropriate for gestational age, your relative risk of mortality is about 20-folds compared to normal term and appropriate for gestational age babies. But if you are preterm and small for gestational age, that risk climbs to about 30 to 40-folds. So this is a very important point to note in terms of community recognition of small babies and interventions that you need to put in place to address those risks. I don't have to tell this audience about breastfeeding. And thank God, globally, Allah Ta'ala has done something about reducing the availability of formula feeds. I don't know the situation in Pakistan, but we have an absolutely close correlation between lack or inadequate breastfeeding and neonatal outcomes. So these are Karen Edmonds' data from some years ago in Ghana, where she was able to identify with Betty Kirkwood that if you delayed the initiation of breastfeeding from, let's say, within the first hour to not feeding in the first 2 days, 3 days, or feeding after 3 days, look at the corresponding increase in neonatal mortality adjusted for reverse causality. We saw it ourselves in some of the studies that we looked at, including one by Dr. Rifat Ashraf in Pakistan, that this risk of excess mortality was not just in absolute terms between those who are not breastfed, but also those who are partially breastfed. So breastfeeding is a very important risk factor for early acquisition of neonatal infections, and that extends to 6 months of age. So if you look at the first 6 months, and you look at those who are not breastfed, not only is diarrhea mortality very high, but also pneumonia mortality and morbidity for both is significantly higher. So breastfeeding or lack thereof is a major risk factor. Let me now turn my attention towards what is it that we can do? What do we know in terms of prevention and possibly management of neonatal infections that could help programming in Pakistan today? So the recent WHO postnatal guidelines make a very strong sense of recommendations across a range of categories, although they do not say much about community interventions, but they do tie this to this new classification by age, which is looking at the immediate first 24 hours, the early neonatal period, and the late neonatal period. So in terms of the various risk factors that we need to address, as I've mentioned, which cause serious neonatal infections, there are the environmental issues that I don't have the time to go into today, but they're extremely important. You can't do much about reducing neonatal infections if you don't have hand washing facilities, if you don't have running water, if you don't have enough attention to crowding and just simple dirt and poor hygiene. We should be able to reduce maternal risks such as preterm rupture of membranes, use clean birth kits at birth, and cord care. And of course, nutrition I've already spoken about. And then we'll talk about treatment, but also things that can scale up treatment, like community platforms and integrated community case management. So let's look into this straight away. First of all, I had looked at this in 2014 as part of the Every Newborn Action Plan. And I will be updating this next year as part of the New Lancet series on newborn survival. But you can see here, if you look at the proportion of child deaths, newborn deaths that are averted worldwide related to infections and what interventions work, a very big chunk is clean postnatal practices, birth practices, and hygienic cord care, right up here. And these account for about 60% of the impact. And there are other things that you see here, like antibiotics for PPROM and micronutrient supplementation to reduce risk from SGA, etc. But this is the gorilla in the room, is to have clean births and clean practices and attention to detail. For prolonged rupture of membranes, the association between risk of chorioamnionitis and neonatal infection, these are integrated outcomes from our review in the same studies where you looked at both the mother and newborn. So clean birth practices are not just important only for the baby, they're also extremely important for the mother. And you can see that clearly in the studies that you outlined over here. Clean birth kits, absolutely reduce maternal morbidity and neonatal morbidity. And of course, over time have been shown to impact neonatal survival as well. Cord care, we know that omphallitis rates can be as high as about 20% in community settings and can be associated with high case fatality rates, particularly with staphylococcal infection. So some years ago, there was a lot of effort on cord application of chlorhexidine, and some of that data was generated in Pakistan by our team, and particularly Dadu, looking at how health workers and importantly family members could apply chlorhexidine to the cord in such unclean situations without necessarily reducing everything else that was going on. So we did not necessarily change practice by reducing what people applied to the cord, but we also asked them to apply chlorhexidine. And across these three studies in South Asia at that time, in community settings, Bangladesh, Nepal, and Pakistan, the overall impact in terms of reducing all-cause neonatal mortality is pretty high, 23% reduction in neonatal mortality. Now, as the evidence is diluted also by studies in Africa with facility settings, we still get close to around a 14% impact. And you see clearly here that the dispersion, the differences between those who applied chlorhexidine and did not apply chlorhexidine had a significant impact on the probability of survival. So that's one of the reasons why WHO adopted it. And I'm a bit disappointed by the fact, and I'll show you in a minute as to what the current recommendation is. One big question that we had at that time was, could the primary care program handle this? Could this be done through a combination with other things? And my colleague, Sean Morris, and our team in Pakistan, led by, again, Syed Sufi, Shaveen Arif, and colleagues, did an evaluation of an integrated newborn kit in the hands of lady health workers in Rahim Yar Khan. And this kit had a number of things to keep the baby warm, to keep the cord clean births. Chlorhexidine, part of that, was a very important component. So this cluster randomized trial took several years, was published in BMJ Global Health, where lady health workers identified pregnancies and delivered these interventions to the families. And basically, the intervention was delivered through the family. They did not do anything themselves, but made the kit available to the families to use after birth. So it was a programmatic intervention in a very pragmatic fashion in this area. And the results showed that, particularly for chlorhexidine, the compliance rates were high. A large proportion used it, but only about a third started on day one. So we should have had 100% doing this. But these are effectiveness trials. You can't change community behavior 100%, but about a third used it on day one. And the impact on omphallitis was highly significant. So although overall we did not demonstrate a change and reduction in neonatal mortality, but morbidity patterns significantly went down, and it was 32% lower omphallitis in the kit in the family group that received and used the kits for umbilical infection. So we looked at that as very promising data over time. Now, to my disappointment, WHO has, in the recent postnatal guidelines, diluted this recommendation of cord chlorhexidine somewhat. And they've said that is only recommended in settings where harmful traditional substances are commonly used on the umbilical cord. Utter nonsense, in my opinion. Why? Because in many low and middle income countries, including Pakistan, the conditions within many birthing facilities in primary care settings, in districts, may be actually worse than home conditions, because there is higher risk of nosocomial or hospital-acquired infections there. So wherever there are dirty births and inadequate attention to hygiene and limited availability of water, I think this remains a very important intervention along with clean birth kits. Breastfeeding I've talked about, and I've talked about neonatal mortality associations, but how do we increase breastfeeding? So Kangaroo mother care, KMC, it has been noted for a long time. And I remember some of the first studies that came out in the 70s of this from Edgar Sanabrias, Ray's work in Colombia. The evidence emerging from KMC on reducing neonatal infections and mortality is very strong. We know this from the existing Cochrane review that it uses, and the use of KMC versus conventional care significantly reduces neonatal infections and sepsis, whether it's used continuously or it's used intermittently. Of course, it has an impact on breastfeeding practices, that babies who have KMC, either intermittent or continuous, do have an increased likelihood of continuing breastfeeding. And the rubber hits the road when you apply it at scale. So I'm going to share you with the recent data from these WHO overseen community implementation of KMC studies, which are done in India. And in a very large sample of babies born at home or discharged early from hospital, Dr. Shabina Arif is currently undertaking a similar large cluster randomized trial in Pakistan, in Sindh, and we'll have those data available very soon. So in this particular study, all of this was done in community settings. And if you look at this, and you look at stable babies who are over 1.5 kilograms, pretty significantly higher newborn survival, 1/3 higher newborn survival. And this survival benefit persisted till 6 months of age. Very compelling studies which have shown now that this saves lives. And in Pakistan, there should be no longer any limitation in terms of applying KMC, maybe not necessarily in a very protocolized manner, but in a manner which is culturally acceptable, that can be used to promote mother and baby contact and breastfeeding. There are many other innovations. I only mentioned 3, which have potential for use in community settings. One is the use of skin protection or use of emollients, particularly things like sunflower or coconut oil, which can be used to reduce damage. So the way it works is that it reduces the amount of damage that you can have on a preterm skin and reduces the entry of pathogens, but it can also have a stimulation and positive effect due to the massage. So I'm going to refer to these 3. First of all, emollient therapy, very high evidence of reduction in hospital-acquired infections. And on sunflower oil, many of these studies were done some years ago. Rihanna Salam in my group did this coconut oil study. She actually didn't do it in community setting. She did it in an NICU and showed a significant reduction in infections. And overall mortality, including this large study by Vishwajit Kumar from India, now shows significant mortality benefit. Now, a lot of this has to be parsed out in terms of how this is applied and what material is applied. But the bottom line is that compared to mustard oil, which is very stringent and damages skin in newborns, the use of some of these commodities may actually protect this in preterm babies and those with vulnerable risks. Amir Imdad in my group looked at vitamin A and probiotics, particularly with the very interesting results coming out of Paniki's work in India, where prophylactic probiotic use in population setting led to a reduction in neonatal mortality. That data needs to be verified, and our group is currently looking at that in Bangladesh. But to summary findings from his systematic review, just published last year, was that there was a pretty decent impact on neonatal infections, with a relative risk of 22.78, 22% reduction in neonatal sepsis, and very high odds of reducing necrotizing enterocolitis and all-cause mortality. So I think the jury is out on probiotics. And if you can find the right combination, there is evidence in terms of its benefit in circumstances where babies may not be receiving 100% breastfeeding. It works through improving microflora and reducing the propensity of pathogens affecting the gut. The zinc supplementation, we've just published this a few weeks ago. The prevention meta-analysis for treatment and prevention. And I will not say much about treatment, but I can tell you that with the prevention arms from these 2 large studies, the overall impact in terms of reduction in the risk of infection is promising. So while we do not recommend just this in prime time, but there is evidence that micronutrient deficiencies can be alleviated somewhat through these innovative new approaches. So what about treatment? I know many people are interested in whether or not community strategies for managing neonatal infections can work. And I've just told you, we have very little data on etiology, which is reliable, and therefore one has to do empiric therapy. The interest in this started by Abe Bang's work in Gadchiroli, some 25 years ago, when he began to look at the empiric antibiotic regime by community health workers. And he found that it reduced neonatal mortality in his group. It wasn't a trial, it was an observational study. After that, a number of studies were set up, and we spent about 6-7 years with these simplified antibiotic therapy trials in primary care settings, some in community settings, looking at neonatal outcomes. And then the most recent ones are the PSBI studies, presumed serious bacterial infections, that our group has also been involved in. So first of all, a number of algorithms out there for trying to detect neonatal infections used by various people, including Anissa that I've talked about, and not a lot to take home between them, that except that the majority rely upon behavior, feeding difficulty, level of consciousness. Respiratory rate, I've already told you, is not very specific, although it may be sensitive, and a number of other things that denote severity or clinically severe disease. Now, these 4 studies looking at simplified therapy in Africa and South Asia are all published and are available, and they showed basically that a combination of amoxicillin and possibly gentamicin worked. And in fast-breathing, amoxicillin worked just because most of those were not sepsis. So WHO came up with these treatment guidelines for reclassifying presumed possible serious bacterial infections, and were able to use that to look at both clinical severe infection and critical illness, and recommended a combination of oral amoxicillin and gentamicin. And they recognized that although they would make extra effort for referral, but in case referral was refused, these could also be used at primary care level. And that led to the implementation research that WHO undertook between 2016 and 19 on how could these management strategies be implemented in routine health systems. Now, this may not be as sexy as large cluster randomized trials, but this is research of the highest level because it's looking at what happens in real health systems and where referral may not be possible, how outpatient treatment at first level outpatient facilities could be provided. And the countries that looked at this were these 6 countries, 10 sites: DRC, Ethiopia, India, Malawi, Nigeria, and Pakistan. And in Pakistan, the work was led by, again, Dr. Shabina was in the audience. I'm extremely proud of the work that Dr. Shabina has been doing over time. So these were about 4,000 families who accepted referral, but they represented only 25% overall. So still a lot of people not accepting referral in various places, including our own geography. As you can tell, and Shabina can talk a little bit more about it, only 17% wanted to go to the hospital. But looking at the quality of hospital, is that surprising? You know, people don't want to travel when they know they're not going to get proper service out there. So in the PSBI approach, across these 83,000 live births with 6,000 PSBI cases, the overall coverage that was possible in this implementation project was about 80%. So they were able to get treatment in 80% and in a large proportion in outpatient settings. So just look at Pakistan, 87% accepted this outpatient treatment by people just coming to the first level facility and getting injectable antibiotics, and 8% agreed to be hospitalized. But this is the important slide, the most important slide. But when you look at data in terms of survival and in terms of the counterpart of mortality, we were able overall to reduce case fatality rates to about 3% for clinically severe disease. Critical illness is a different issue, but even here in the small 4% subpopulation of PSBI cases, case fatality rates were about 11.9%, which I think is as good as can be achieved in this circumstance. So this approach does have the potential to save lives, and it is a combination of pure community and primary care setting and very promising data overall. It does mean that newborns would need to be assessed, that newborns need to be seen, and people need to be trained about assessing newborns for danger signs earlier on, so a decision can be made in terms of treatment at first or second level facilities. And these are part of the current recommendations that just came out from WHO on postnatal care. So let me conclude by saying that in this vast field, there is enough evidence to indicate that your colloquium is very appropriately focused on a major global burden of newborn mortality and morbidity. And these serious infections account for a large proportion of neonatal mortality. There are a number of options for prevention, but they are context dependent, and community and population setting preventive strategies are all cost effective and available in low and middle income countries like Pakistan. And sometimes there are no options but to do that for where most of the deaths are clustered. Clean delivery, early exclusive breastfeeding are probably the most promising preventive strategies. They are within our grasp. And the Pediatric Association, the Neonatal Colloquium, and people here ought to really prioritize getting clean delivery up there. And it's not just important to get facility births. They have to be done in the right context with all the caveats that I've mentioned. Empirical therapy based on validated clinical criteria remain the best approach, and we now have the PSPI experience to treat presumed serious bacterial infections in the newborn, and we have evidence that this can save lives in primary care settings. However, I believe that for a range of other reasons, including preterm care and including addressing birth to 6 years, we really need to maximize facility births, quality facility births, and tiered regionalized care for small and sick newborns. And the survey that we are undertaking right now is principally to see what may be the implications of this for our national planning. So I think absolutely your conference is timely. Pakistan needs to completely revamp its integrated maternal and newborn strategy with a strong emphasis on infection prevention and management if we are to reach the Sustainable Development Goal 3 targets. And those targets are ambitious. Let me finish by just showing you what those targets are. Is to reduce neonatal mortality to 12 or less by 2030. We're sitting in 2022. In 8 years, the global target that we signed up to is to bring neonatal mortality from the current 40 to 12 or less across the board, which means that you will have to have quite a significant reduction in many high burden districts and areas. It may seem impossible, but it is only impossible until it's done. And therefore, I hope that your conference and some of what I've submitted to you may go some way in helping Pakistan achieve this. Thank you very much for your attention.